Coming to the next question, the most common factor that is responsible in implant failure, the answer is lack of the primary stability. So the first option is the plaque accumulation. So if there is a significant buildup of plaque around the implant, that can lead to condition that is known as peri-implantitis. So what is that? It is a inflammatory condition that will affect both the hard and the soft tissue around the implants. So the plaque accumulation, it can cause inflammation, infection and bone loss that leads to the implant failure. So proper oral hygiene and regular maintenance, they are important to prevent the plaque related complication. The second is the osseous bone graft. So in case where bone graft, they are used to augment the jaw bone before the implant placement, graft failure can occur if the graft it does not integrate with the existing bone. So insufficient integration of the bone graft, it can lead to inadequate support for the implant. So that would ultimately affect the stability and the osteointegration. So the lack of integration can lead to implant failure. So the most important factor responsible in implant failure, it's the lack of the primary stability. So primary stability refers to the initial mechanical stability that is achieved during the implant placement. So if the implant it lacks sufficient stability at the time of placement, it may not properly integrate with the surrounding bone. So that can lead to complication during the healing period, and that could lead in the implant failure. Option D is inability to use the T-scan for the load determination. Now the T-scan, remember T-scan, it is a tool that is used to, so this one is the T-scan. So it is a tool that is used to measure the bite force distribution. And is used to determine the occlusion forces on the dental implant. So it helps to determine the optimal load for the implant that should be there. So the answer is the most common cause of the implant failure is due to the lack of the primary stability. Coming to the second question, another question. All of the following statement regarding the self-cure as compared to heat cure are true, except the answer is D, the self-cure, it has more transfer strength. So this one is the difference between the self-cure and the heat cure. So the option A, the self-cure, remember it has a low average molecular weight, high residual monomer content. So option A is correct, option B is correct, option C is correct. The porosity is greater, the self-cure has a greater porosity. So the answer is option D only, the self-cure has more transfer strength. So remember this table for your entrance examination point of view. Coming to the next question, on intraoral examination of female patient, there is a grayish whitish lesion on the buccal mucosa bilaterally near the occlusion plane that disappear on stretching. So your diagnosis would be, the answer is this is leukodema. Leukodema, we know it's a benign common variant of the oral mucosa. So there would be asymptomatic bilateral white gray semi-transparent macules that are present on the buccal mucosa. So the main characteristic feature is that the lesion would disappear when the mucosa is stretched. So that helps you to differentiate between leukoedema from other white lesions. The leukoplakia, it is term that is used to describe the white patch on the oral mucosa that cannot be wiped off. So it is generally pre-malignant condition. The friction keratosis, it is response of the oral mucosa to the chronic irritation or trauma. Unlike the leukoedema, the frictional keratosis may not disappear on stretching, and its appearance it is associated with the localized irritation or the trauma. Now the answer is leukoedema. Leukoedema, remember, it's more common in blacks than in white, and prevalence is in black, it is around 70 to 90%. So there would be diffuse white, milky and opalescent appearance of the mucosa as clearly seen here. So the surface, they will appear folded, that results in a wrinkled appearance or whitish streak like appearance. So the lesions are typically bilaterally seen, most commonly on the buccal mucosa. So the white appearance, the most important feature is that the white appearance would diminish or disappear when the cheek is stretched. So that is the characteristic feature. So on biopsy, you can see is increase in the thickness of epithelium. There can be edema of the spinous layer and cells that are large with pycnotic nuclei. So in the context of MCQ, the key feature mentioned is the disappearance of lesion on stretching, which aligns with the clinical characteristic of the leukoedema. So therefore, B is the most likely diagnosis based on the provided information. Coming to the next question, a hemophilic child underwent lower first molar extraction. Bleeding could not control after extraction. Which of following we give to control the post-operative bleeding? Now, in a hemophilic patient who has undergone a dental extraction with uncontrollable bleeding, so we should give is a aminocaproic acid. So remember, it is a aminocaproic acid. It is a synthetic lysine derivative, and it has a antifibrinolytic activity. So it will directly inhibit the proteolytic activity of the plasma. So what is its use? It is used in the treatment of hemorrhage and prophylactically against the hemorrhage, including post-surgical hemorrhage. So the mode of action, it's the aminocaproic acid. It completely inhibits the activation of plasminogen. By doing so, it will reduce the conversion of plasminogen into plasmin. So that is an enzyme that is responsible for degradation of the fibrin clots, fibrinogen and other plasma proteins, including procoagulant factors like factor 5 and factor 7. Protamine sulfate, it is remember, it is used to reverse the anticoagulant effect of heparin, and it is not indicated for controlled bleeding in a hemophilic patient. The heparin, it is an anticoagulant, and it would not be appropriate for controlling bleeding in this context. Option D is the whole blood plasma. Well, the whole blood plasma transfusion may be considered in case of significant bleeding, but addressing the underlying issue of hyperfibrinolysis with aminocaproic acid, it is more targeted approach. So in the summary, use of the aminocaproic acid, it is suitable for scenario because it helps to control the bleeding by inhibiting fibrinolysis and stabilizing the blood clots. That is important in hemophilic patient who has undergone dental extraction with persistent bleeding. So option A is correct. Coming to the next question, the cardiac patient penicillin drug given to prevent endocarditis, it's So clarithromycin is the it is given, or azithromycin should be given in patient who are allergic to the penicillin. So those patients who are unable to take the oral medicaments, we can give them is ampicillin, either IV or IM within 1 hour before the procedure. And patient who are in allergic to that, they can be given cephalexin, clindamycin, etc. So another point that you have to remember for your exam point of view is that the endocarditis prophylaxis, it is recommended in the prosthetic cardiac valves patient, congenital malformation, rheumatic heart diseases, mitral valve prolapse, etc. These are the recommendation, and these are where it is not recommended. So these question can also come in your entrance exam, remember that. Coming to the next question, a patient comes with the pain in the pharyngeal region and is having carcinoma of the nasopharynx and giving history of middle ear deafness. So here the answer would be Trotter syndrome. So Trotter syndrome, remember, it is indeed characterized by clinical triad of there could be unilateral deafness, second neuralgia that is affecting the branches of trigeminal nerve, and third there is defective mobility of the soft palate. So the syndrome, it is associated with the malignant tumors involving the lateral pharyngeal recess. So it aligns more closely with the scenario described in the original question, where the patient has pain in the pharyngeal region and he is experiencing the middle ear deafness due to carcinoma of the nasopharynx. So therefore, based on that, Trotter syndrome would be the answer. So these are the other options. Remember that the Eagle syndrome, where there is dysphagia and pain, it is due to the elongated styloid process. So the Trotter syndrome other is, and the third is the Horner syndrome, where you will see ptosis, meiosis, and anhidrosis, along with that vasodilation. Coming to the next question, a 26-year-old male patient presented with multiple keratocyst basal cell carcinoma on the right cheek and disc keratosis with bifid rib. Your diagnosis would be Gorlin syndrome. Well, the multiple keratocyst basal cell carcinoma and disc keratosis with bifid rib, it is a consistent feature of the Gorlin-Gose syndrome. So Gorlin-Gose syndrome, it is characterized by multiple basal cell carcinoma, OKC, multiple OKC, skeletal abnormalities where you can see if the bifid rib, palmar plantar pits, etc. So remember that this syndrome, it is due to the deficiency, it is caused due to the mutation in the PTCH gene. That is just that you have to remember, and it is important for your exam point of view. Coming to next question, a patient who has a portal hypertension hematesis, on further examination you will see him esophageal varices were formed. Which vein has anastomosis with the coronal vein to cause this? The answer is a splenic vein with the left renal vein. So imagine the blood in your body is like a car that is moving on highway. So in your liver there is a big intersection that is known as a portal system. So from where the blood from your digestive tract, like the stomach and intestine, it meets near the blood from the spleen. So the liver, it works like a traffic cop, directing and controlling the flow. So now if there is problem with the liver, like there is a cirrhosis or the traffic is getting jammed, so that causes pressure in the portal system. So like a traffic is jam on the highway, the blood looks for other way to get back to the heart, creating side roads. So one of these side roads involves the splenic vein. And the left renal vein. So they start talking to each other and creates a shortcut. So shortcut is known as anastomosis. So this is like a car finding a new route to avoid the traffic jam. So but this shortcut it leads to veins around the esophagus. So these veins in the lower part of esophagus can get enlarged and swollen like balloons filled with blood. So these are known as esophageal varices. So now when these varices get too full, they can burst, causing bleeding. So this bleeding can result in hematemesis, that is vomit of the blood. So answer is splenic vein with the left renal vein. Coming to the next question, identify the structure seen. It's the right primary bronchus. The next question, identify the midline movable cyst of the head and neck region. Well, it's the thyroglossus cyst. The thyroglossus cyst is a midline movable cyst that is found in head and neck region. It arises from the thyroglossus cyst, that is duct. The common side are most common. It involves the subhyoid region. The second most common is at level of the thyroid cartilage, or it can be at the floor of mouth. So the most common is a subhyoid. At level of thyroid, it is the second most common site. The foramen cecum, it's very rare. So these are the points that you have to remember for your exam. Most common type of thyroglossus cyst is subhyoid. The thyroglossus cyst, it moves upward with the tongue protrusion and it is connected to the base of tongue. So the cyst, it is typically midline and movable. It moves upward with the tongue protrusion since it is connected to the base of tongue. So in some cases you can note that there can be thyroid fistula. So this thyroid fistula, it is due to the surgical incomplete removal of the thyroglossus cyst. Coming to the next question, a HIV patient come to dental clinic on examination, gingival recession noted on the lower anterior hair. What could be the associated condition? The answer is NUP. So when HIV patient presents with the gingival recession, the associated condition could be necrotizing ulcerative periodontitis. So NUG, it is an inflammatory condition that affects the gingiva. So there would be bleeding, ulceration and presence of gray pseudomembrane. If NUG progress and it involves the underlying periodontal structure, it can lead to attachment and bone loss. So this advanced form is known as SNP. So in HIV patient, the immune system can contribute to development and progression of the periodontal disease, including the necrotizing condition. The next question, what is the space maintainer to be used for bilateral loss of the molar in a 7-year-old child? It's the lingual arch. So lingual arch space maintainer, so it can be used bilateral For the unilateral loss of the mandibular first deciduous molar, the option can be band and loop space maintainer. While facing bilateral loss, the lingual arch space maintainer is considered suitable. The next question is the appliance should be worn for duration of. So this appliance, remember, it should be worn for duration of. This is a petit face mask that is wear for 14 to 16 hours every day. So it is used mainly at night. Additionally, it is used at some period during the day. So a total recommended period it's 16 to 18 hours every day. So answer is C. The pregnant woman infected with the toxoplasmosis, what antibodies they are present? The answer is IgM. So IgM antibodies, they remember, they are the first antibodies to be produced in response to toxoplasma infection. So they are present in most individual within a week or 2 years after the initial exposure. The IgM antibodies production they rise for short time period and it declines. So the level of IgM antibodies may fall below detectable level after the initial infection. So that is why the presence of IgM antibodies it is significant as there is indicate the recent or active infection. IgG antibodies, while they are also present, they provide the long-term protection and persist in the bloodstream for rest of person life, indicating the immunity. All of following are true regarding the superficial burn, except the answer is heal with scarring. The superficial burns, they are red color, involves only the epidermis. So they do not lead to scarring and their healing is rapid with reepithelialization within short period. Scarring it is most commonly associated with the deeper burns and in case of superficial burn minimal to no scarring it is expected. A 54-year-old patient complained of swelling in anterior maxilla between the canine and the lateral incisors. The lesion is almost two-thirds of the female and it generally seen in anterior maxillary region. Your diagnosis would be edematoid odontogenic tumor. It is commonly seen in the anterior region of maxilla, seen in young age groups with the prediction for the females as mentioned in the figure. There would be facial asymmetry due to the swelling. Lesions can enlarge and on radiograph you would see unilocular radiolucency. So the location that is the anterior maxilla, prediction for female, asymptomatic nature and radiological feature, they are consistent with adenomatoid odontogenic tumor. Identify the gland. Well, it's the holocrine gland. So these glands, like the sebaceous gland, they produce oil to lubricate the skin. So the cells in holocrine gland collect their excretory products inside and then burst open to release it. So it's like a cell self-destruct to get the job done. The second are the merocrine glands. The example are the salivary glands. The merocrine glands release their secretion directly through the cells or the plasma membrane without harming the cells. So this process it is known as exocytosis. The apocrine sweat glands, they release their secretions into the hair follicles. Apocrine sweat glands, they are found in specific areas like armpit, breast, nipples, ear canals, eyelid, and genitals. So in simple term, holocrine glands, they will burst open to release their content. Merocrine gland release without any harm, and apocrine sweat glands release their secretion into hair follicles in the specific area of the body.